So next is breast surgery, and the first is V1, advanced breast cancer. 48-year-old premenopausal woman who underwent white local excision and axillary sampling 8 years previously presents with a new lump deep to the scar and palpable axillary node. Describe your initial management. So I will take a history duration of symptoms, associated symptoms like weight loss, breathlessness, and back pain, bone pain. Details about previous breast cancer treatment and pathology, and complete a triple assessment, perform an examination including supraclavicular foci, liver, lungs, vertebrae. Request imaging including mammogram, ultrasound scan for breast and axilla with core biopsy of the lump and core biopsy for a final aspiration of the nodes. Request details of previous breast cancer treatment, previous imaging and pathology slides for a review in MDT. Core biopsies confirm recurrent invasive lobular cancer, grade 2, ER-LRED score 8/8, HER2 positive on fluorescent in situ hybridization. Imaging shows 25 mm mass with several suspicious axillary lymph nodes. She previously underwent radiotherapy and took tamoxifen for 5 years. What further investigations would you recommend? So blood test, full blood count, UNEs, calcium, LFTs, CEA, cancer antigen, CA15-3, and staging CT chest, abdomen, and pelvis, astro bone scan to look for METs, bone in deposits in the long bones and the skull and the vertebrae. If recurrence not visible in mammography, MRI may be of value in assessing the contralateral breast because it's a lobular cancer. Staging CT shows metastatic nodules in both lungs and involved internal memory nodes. What systemic treatment would you suggest? So I would suggest oxygen suppression, LHRH agonist, that's Zola, Gozirellen, or surgical aberration. So in medically it's called Zoladex, 3.6 milligram subcut for 28 days. After an aromatase inhibitor, after oxygen suppression has been achieved. So chemotherapy, especially if symptomatic from distant METs, consists initially of anthracyclines. If disease progression on anthracycline, first line docetaxel, second line vinorelbine or capecitabine. And trastuzumab is given in combination with the taxanes because of the associated cardiotoxicity. Avoid use with the anthracyclines. Monitor the cardiac function by MOGA scan or echo, and continue as a single agent while disease is responsive. If brain mets develop, trastuzumab does not cross the blood-brain barrier. Continue trastuzumab and treat mets with surgery and radiotherapy. So Herceptin it can be given either IV or subcut, and there are two regimens, either weekly for 1 year or every third week for 1 year. And then pertuzumab may be given in combination with trastuzumab and docetaxel. If relapse occurs with trastuzumab, I would consider lapatinib in combination with capecitabine. Is there a role for primary surgery? It is used for local control if someone has a fungating tumor. Discuss the role of axillary clearance and MDT. Give only further prognostic information because patient already being offered chemotherapy. This would prevent axillary recurrence in future. There is a possible survival advantage in removing primary disease. Post-operative complication can delay systemic treatment, resulting in a worse prognosis. 5 months later, she developed severe lower back. A repeat astro bone scan confirms an isolated vertebral bony mets. What treatment can you offer? Bisphosphonates, pain control, and systemic therapy regime change due to disease progression. Switch from the tamoxifen to aromatase inhibitors and from aromatase inhibitor to exemestane. And pain control with simple NSAIDs, analgesia, or external beam radiotherapy, single fraction 8 gray. And bisphosphonates, either it's alendronic acid or abendronic acid, it inhibits the osteoclast activity, stop the bone resorption, and reduce the risk of further skeletal morbidity. And side effects include renal impairment and osteonecrosis of the jaw. Possible increased risk of esophageal cancer. Should be taken with water on empty stomach. With the patient needs to remain upright for 60 minutes with no further intake. Thank you.